Okay, this is a case study about Lily. She is a 3-year-old female who presents with complaints of abdominal pain and fever since yesterday. Her subjective data, the lower abdominal pain, fever for 24 hours, and Lily has been wetting her pants despite being recently potty trained. Her objective data, vital signs 38.5, temp 114, pulse 32 respirators, BP 104/62. Urine is positive for WBCs, nitrates, and blood. What risk factors does Lily have for a UTI? Her risk factors include her being female, and the female anatomy does predispose us to urinary tract infections. Another risk factor for Lily is that she's recently potty trained and she has infrequent bladder emptying. I think we talked about this in other lectures about how kids have a hard time stopping playing to go to the bathroom, to eat. It leads them into some issues. One of them could be a urinary tract infection. Poor hygiene, and again, poor hygiene just could be she's new to going to the bathroom, and is she wiping correctly? Is she wiping from the front to the back? Lack of fluid intake, again, if she's playing, if she's busy, taking fluids probably aren't going to be the most important thing in a 3-year-old's life. Another risk factor could be just an undiagnosed congenital abnormality. We would want to make sure that we are making sure that that doesn't exist as well. What might prevent Lily from a recurring UTI? Again, making sure, just good education, proper hygiene, making sure that the mom or whatever parent, whatever caregiver is with her, that knows that Lily should be wiping from the front to back, that we should increase her fluid intake, so she needs to stop playing, to take drinks frequently. And then we also need to promote frequent bladder emptying, so making aware of when Lily's going to the bathroom and how often. What should the nurse do in this situation? Prioritize your actions. You would definitely want to monitor Lily's vital signs, what's going on with all of those numbers. The temp is elevated. What's going on with their pulse and respiratory rate? That could let us know that maybe the urinary tract infection has gone systemic. We would want to obtain the urine right away, clean catch if possible. If not, catheterize Lily. So we would want to get that urine specimen, send it out for a urinalysis, and then culture and sensitivity, so we know what medication to put Lily on. Make sure Lily doesn't have any allergies, and make sure reinforcing medication administration with the caregiver so that Lily takes all of the prescription. Those are just some of the highlights on that case study. And then, let's see. Trying to find the other one. Okay. Let me find it on, whoop. Okay. We have 7-year-old Jason. He's hospitalized with acute glomerulonephritis. He weighs 48 pounds. On admission, his blood pressure is 120/80. His pulse is 80. His respirators are 18. His urine is dark brown and contains 3+ protein. His urine output has been 40 mLs in 2 hours. And Jason's mother states he has real puffy eyes in the morning. A normal BP for somebody Jason's age, the diastolic should be anywhere from 97 to 118. And did I say diastolic? The systolic should be anywhere from 97 to 118. And the diastolic should be anywhere from 60 to 76. So just slightly outside of the norm. So based on this information, I kind of want you to look at what's your assessment data. We take a look at the blood pressure. We said it's slightly elevated. What's going on with his pulse? What's going on with his respirations? His urine, we know that it has protein in it and it's dark brown. He has periorbital edema, and we know that he's 7, and in kids, edema often starts around the eyes, especially the younger the kid. And we know that his urine output is decreased. We would want to look at labs. We would assume in the urine being dark brown, he's going to have some hematuria. Specific gravity is probably elevated due to the dehydration. If we're looking at Jason's blood, I would expect that his protein levels are elevated, and that his potassium could be elevated, and his strep titer possibly could be elevated as well. Some general signs and symptoms we could see, does he have any abdominal pain, any malaise, anorexia, vomiting, pallor? Is he irritable? Is he lethargic? Does he have a fever? Regarding the blood pressure, if the blood pressure is elevated, we could ask him if he has a headache. If he does have a headache, we could worry about encephalopathy, seizures, neuro changes, and make sure we're addressing pain, neuro assessment. For the edema, is it progressing? Is it in the abdomen with ascites? Is it in the lower extremities? Has it progressed to full body edema? That would be anasarca. So again, don't forget, when we're worried about edema, we want to monitor the weight closely. The next thing I kind of want you to think about with the case study is what orders are we going to give somebody with Jason, or somebody like Jason? What orders do you want the doctor to order? If you want to pause the tape right now, think about it, and then I will spit out my answers. I would think that I would be ordered to check his blood pressure at least every 4 hours, that I need to monitor his weight, his INO. I could check his abdominal girth, check every urine for specific gravity and hematuria. I would want to document and note the edema. Is it progressing? I may put him on a fluid restriction. His activity order would probably be bed rest, especially with that hypertension if we're worried about encephalopathy and seizures. If he's on bed rest, I need to think about position changes and skin care. I would, if his strep titer came back positive, I would anticipate an antibiotic. I could anticipate an antihypertensive. I could anticipate a diuretic to get rid of that fluid. And if I have so much fluid on board, I could anticipate digoxin being ordered for the heart failure. Diet, regular diet, but no added salt. I may need to stimulate his appetite to get him to eat. Small portions, appropriate favorites include the family and meal times, making them as normal as possible. Depending on what's going on with his potassium, I might need to, depending on what's going on with his potassium and his urine output. If he's not having any urine output, remember we said we can't give any potassium, we might need to restrict it. And then if his potassium is elevated, we think about protein as well. In protein restrictions as well, what's going on with those kidney functions. Look at the BUN, look at the creatinine. I would anticipate the need for Jason to need some diversional activities. I want to assess pain. Any other areas of infection is fluid volume, nutritional status, no sick visitors, keep them warm, standard precautions. Those are just a few of the things that I came up for my orders with Jason. Okay, the other things you need to think about with Jason is, how do you know he's improving? Again, why don't you pause the tape and come up with some ideas on your own and then correct yourself. The answers are that I have, he has a normal fluid balance. So if he has a normal fluid balance, his weight is stable, his vitals are stable, no pain, his labs look good, we're not seeing any edema. He has some urine output, INO looks good. Urine, we see a decrease of protein in the urine, a decrease of blood. He's active, he's eating. There's no signs and symptoms of infection anywhere else. And then the other things I want you to think about with Jason is his discharge teaching. So again, maybe stop the tape and or pause your recording, and then come up with some of your answers. And my answers are, our discharge teaching is he would still need to check his urine at home with a dipstick. We're looking at protein and blood is in the urine still at home. Occult hematuria may remain for months after he goes home. Remember I talked about activity restrictions until there's no hematuria. It could last a while. And as we see the gross hematuria going away and he starts to become more active, if we see hematuria coming back, he needs to back off on his activities. Low sodium, low potassium diet at home, lots of follow-up care with the doctor. Subsequent recurrences are rare due to specific immunity has been conferred. Remember, 95% of these kids have a complete recovery. 5 to 15% will have chronic glomerulonephritis, and 1% do have irreversible damage from the disease process. All right, so that's what I have on glomerulonephritis.